Hi, everyone, and welcome back to the Psychiatric Mental Health Nurse Practitioner Exam Prep. Today, we're going to be talking about personality disorders. So, what is personality? It's the sum of our emotional, cognitive, and behavioral attributes that make up who we are as a person. It involves a pattern of how we perceive the world, the things we relate to, and how we think about the environment and how it affects us. When there is a healthy personality structure, it allows for realistic, happy, and satisfying self-perceptions and interpersonal interactions. Characteristics include the personality is organized by early in life and is dynamic and deeply ingrained. However, it can be altered, although it is tough. Patterns of behavior display what are based on personality can be perceived by the person as comfortable or uncomfortable. So within our personality, we have the ego. This is the perception of ourself in contrast to another person. Things can be ego-systonic, so behavior that is consistent with our personality causes agreement or little concern to the person. The person generally fails to recognize the problem, and the person does not seek treatment. There's also ego dystonic, so the behavior is inconsistent with the personality. It causes discomfort, disagreement, and concern to the person. A person generally recognizes the problem, and the person often seeks treatment. And personality is reflected in behavioral traits habitually displayed by the person. And then coping can be interpersonal and interactive style, perceptions, cognitive beliefs about events, person, and situations. The thing to know to this is that ego-systonic can be recognized by how we feel about something. If it's something that we feel like we agree with, it doesn't concern us, that's ego-systonic. And if it's something that disrupts the person, it's ego-dystonic. Now, when it comes to personality disorders, something that is ego-systonic to me, like something that I feel like I would be proud of and that I agree with, and it doesn't cause concern to somebody else based on their personality, could be ego-dystonic. So it's really based around the personality and the person. It can change, right? And that's important to our personality. This is just, I guess, a fun fact. This is how we differentiate OCD from a personality disorder. I'm trying to think of an appropriate example to give. Because sometimes with OCD, the obsession, so the thought about things, all right, the way I'm going to make this appropriate is some people may get a thought in their head that would be very disturbing to others. Okay, let's just say killing animals, right? A person might be thinking about ways in which they'd kill an animal. It's all they think about. They can't stop, right? Well, if you ask them, like, how do you feel about that thought that you're having? If they say, it's disturbing, I don't like it, I want it to stop, right? That's symptomatic of OCD. But if they say, I've always wanted to do it, I can't wait to do it, it's something that I've planned out multiple times in my head, right? Now we're talking more personality disorder, because that thought to somebody with OCD is ego dystonic, but that thought to somebody who has, let's just say, antisocial personality disorder, right? That thought would be ego systonic. So, and typically this manifests in more inappropriate ways, but that's the best one I could think of right now. That is not inappropriate. Okay. So let's keep going about personality disorders. These are very interesting. So we have cluster A, cluster B, and cluster C. So our cluster A, these are our odd, unusual, eccentric, asocial personality disorders. There are 3 types. So we have our paranoid personality disorder, and we're going to go over all of these in very fun ways. Schizoid personality disorder and schizotypal personality disorder. Then we have our cluster Bs. These are kind of the more dramatic and affective instability. These are going to be our antisocial personality disorders, our borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. And then we have cluster C. This is our anxious type, where we have avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So one of the big things with personality disorders is everyone's personality is going to have certain components of personality disorders, right? So for example, narcissistic personality disorder. I see this time and time again in the world where people will say like, they're a narcissist or something, right? But are they, or are they just really confident? You know what I mean? Like people can have components. So where we really can get the definitive, or like what is helpful in differentiating, like, is it just kind of traits of these things, or is it people misconstruing, is really the interpersonal difficulty. People who have difficulty with relationships with others, and not just like romance, but like friends, family, things like that. That's where we can see like a consistent pattern of interpersonal difficulties equals personality disorder. So that's that. All right. So personality disorders are chronically maladaptive patterns of behavior. Again, patterns of behavior that cause functional impairment in work, social, and relationships. These disorders manifest as maladaptive patterns in 4 areas of functioning. So there's maladaptation in affective traits. So persistent and consistent emotional displays. So the way in which they display emotions are maladaptive. They could be overly effectual patterns of response, and then maladaptive behavioral traits. So persistent and consistent odd related actions to others and themselves, such as poor impulse control or patterns of response, like the way they respond to situations is odd. Yes, we'll get into more. It's going to depend which one, which personality disorder, the way in which they're going to respond. Maladaptive cognitive traits, so persistent and consistent cognitive distortions and information perception, so such as unrealistic perceptual patterns of response. When we talk about cognitive distortions, lots of different diagnoses we can kind of see cognitive distortions. These are things like, no one likes me, or like, you don't do well on one test and it's like, I'm dumb, right? That's a cognitive distortion. It doesn't make sense if we look at the actual, evidence, it doesn't support, right? Like, let's say you're in nursing school, you fail one exam and you're like, I'm so dumb. But like, actually, if you look at the evidence, you've gotten into nursing school, you passed the prep test, nursing school acceptance rates are super low and you were able to do that. So it's like, you know what I mean? It doesn't add up. Where, again, we differentiate the personality disorders, specifically, especially the cluster B, is that interpersonal difficulty. That's like the main thing. Maladaptive social traits. Maladaptive, unsatisfying interpersonal patterns of response. So again, this is interpersonal. People with personality disorders classically have defense mechanisms that are primitive and inefficient to help them cope with intense affects. So such as fantasy, splitting, and projection. So when we say splitting, what this means is like, you'll say like, you're the good parent, the bad parent, right? Or, in like inpatient units, we can see this sometimes with staff. Like, I like this staff, but I don't like this other staff. In friend groups, right? There's that person that's like, I like this friend, but I don't like that friend. That's splitting. Projection is taking things that maybe you think about yourself and projecting them onto others. That's kind of like projection. Or things that maybe you feel about others, like you might then project that they feel that way about you. So secondary personality disorder is characterized by a change due to another medical condition or primary mood disorder or psychotic disorder or substance use disorder during periods of remission from the underlying cause. The secondary personality disorder traits should abate. So things like delirium, neurocognitive disorder, CBA, traumatic brain injury. Typically, personality disorders are seen young and go throughout the life. So these disorders can cause subjective distress. So a person is unlikely to recognize the problem or seek help if their maladaptive pattern of behaviors are egosystonic. So we talked about that. If the way they are acting, they agree with, and they think they're right, they are not going to change. A person is more likely to recognize a problem and seek help if maladaptive patterns or behaviors are ego dystonic. So again, if they don't agree with the way they're acting or what they're doing, and they can see that and they want to change, then they may. Maladaptive patterns are inflexible and perseverative across most personal and social situations, and individuals often exhibit features of several similar personality disorders. So you'll see this, right? And the most common that you're going to see are cluster B, because they're the most kind of like in your face personality disorders. But you'll see people who are, the borderline personality disorder is the dominant one. However, they have features of narcissistic personality disorder or features of histrionic. They do kind of go together. So yes, you may see that as well. So there's two common types of theories of how personality disorders happen or develop. So the first one is the psychodynamic theory, and this is object relational theory, which is based on two factors. So factor one is early separation problems. So behavior manifests as a primitive coping strategy in the response to distress during infancy to adolescence. This psychosocial distress may stem from separation problems. So the child experiences an inner struggle from interpersonal relationships that alter normal development. This unresolved distress alters the child's perception regarding the stability and development of the caretaker role. The child fails to develop separation and individualization. So separation is the development of intrapsychic self representation distinct and separate from the mother. And individualization is a form distinct identity with characteristics unique to that person. So failure in separation and individualization is etiologically linked to the development of personality disorders. Different personality disorders linked to problems with different stages of separation in the individualization process. There are 4 stages. So differentiation at 6 months of age, where the child progresses from visually checking back to playing nearby. The child may use a transitional object to soothe separation anxiety from the caretaker. Difficulty in this stage is thought to give rise to borderline personality disorder. Practicing, so from 6 months of age through 18 months of age, as the child begins to have more autonomy, the toddler fearlessly walks and explores the world. The child engages in games that reassure of consistency of the caretaker as well as independence of the child. Problems in this stage give rise to the development of narcissistic personality disorder if the child is unable to maintain a healthy sense of self-regard. There's rapprochement, so from 15 months to 24 months, and is characterized by the child realizing their limits. A normal increase in aggressive behaviors causes the child to pull away from and run towards the caregiver as a child attempts to reconcile autonomy with their needs for others. Problems in this stage give rise to borderline personality traits of splitting and projection. And then object constancy, so at 24 months to 36 months of age, when the child feels stability of the caretaker's dependability, they are able to hold the image of the caretaker in their mind while distinguishing their own identity of that in others. Object constancy is the ability to retain a bond with a person, even if they find themselves upset, angry, or disappointed by their actions. Problems in this phase can rise to schizoid personality disorder, narcissistic or borderline personality traits. So they can have disturbed parental interaction, family background assumed to be dysfunctional. So there can be enmeshed family patterns, which are overly connected and needs to meet the other person's needs so badly that they lose touch with their own goals and desires and feelings. There can be role reversal patterns where the child acts more like the parent. There can be restrictive involvement of family with the rest of the environment, social isolation, confusion of parental authority and nurturing roles, and blurred family boundaries. Factor 2 is a dysfunctional family pattern. Block separation, individualization processes. Family rejection occurs if the person attempts individualization. Then we have biological theories, so genetic factors, so familial tendencies and genetic overlap loading for some axis 1 disorders and personality disorders. Structural abnormalities, so reduced grade matter in the prefrontal cortex and limbic system dysregulation. neurotransmitter dysfunction, so decreased serotonin, elevated levels of norepinephrine, and dysregulation of dopamine receptors, and neurobiological impact of trauma. So most studied in borderline personality disorder, they're actually starting to some places call borderline personality disorder complex PTSD, which I actually think is not a good name just because it's too close to PTSD. I don't think that's the best name. Or complex trauma. I guess that's what they call it, complex trauma, but it's too close to PTSD, I think. But that's a name people are calling it. Assumes early childhood trauma alters basic brain patterns, and in genetically susceptible people, many function as their environmental vulnerability that causes the expression of the genetic load. So pretty much their environment turns on the genes is the thought. So for history, we want to assess for details of the present illness, including time frame, progression, and associative symptoms. We want to look at their social history, their living situation, marital status, occupational, educational, drug use, prescriptions, validate history with a family member, because again, the way they see the world is not the actual way that the world is typically. Long-term patterns of functioning and their traits across different situations. Again, you're going to see interpersonal conflicts with a lot of these in multiple settings. It's not just like two people, right? It's this person with everyone else is the problem but them, that kind of thing. And cultural issues versus maladaptive personality traits. We always want to look at cultures and how they function, because what is one thing to one culture is something different to another. So it might just be like a cultural practice that they're exhibiting. All right, so our cluster A disorders, these are our schizotypal, paranoid, and schizoid. And there's going to be patterns of pervasive distress, suspiciousness with odd and unusual behavior, which presents in a variety of situations and contexts. It's usually not to the psychotic level, but can display brief psychotic episodes under stress. Differences in cluster A disorders are in degree of suspiciousness and mistrust and in behavioral manifestations of those traits. Significant history includes the following. So limited social network, poor interpersonal relationships. We're going to see that with all of these. Limited disclosure and revealing of self to others, often refusing to answer personal questions. Compliments often misinterpreted, pathological jealousy common, difficult to get along with, appearing cold and lacking of feelings. High control needs, rigid, often like threatening lawyers and things like that, negatively perceive others. So and we're going to talk more about each disorder. There's a lot of overlap. Kind of like the main points, the schizoid is kind of the more aloof, solitary, unaffected by praise. Schizotypal is like odd and eccentric, and then paranoid's like very paranoid. And we're going to go more into these. All right, so paranoid personality disorder. So pervasive, persistent, consistent distrust and suspicion of others. They often think their motives are malevolent, unjustified, suspicious of others or trying to harm or injure or deceive them, preoccupied with the doubts of others, reluctant to confide in others because they think it will be used against them, and then believing others are out to harm them, doubting the loyalty of others, holding grudges, taking criticism poorly, perceiving others' character. We get the gist. So for each of these personality disorders, we are going to have a movie character. Most of them are related to Harry Potter. There's a few others sprinkled in there. But I think it's the best way to really capture those symptoms of these disorders to give them a face to the name. So paranoid, and some of them are a stretch, right? Because the movies don't always display them all perfectly, but they're the closest I could find. So we have from Harry Potter, Moody, right? He's always suspicious of people. He's always like paranoid of others. So he's a good one. Then we have schizotypal personality disorder. So this is a pervasive pattern of detachment from social relationships and restrictive range of expression of emotions in interpersonal settings. They neither desire nor enjoy close relationships. They choose to live in solidarity. They show little or no interest in sexual activities with other people. They derive no pleasure from social activities. They lack close friends or social supports. They're indifferent in opinions to others. They appear cold and detached, and they exhibit affective flattening. So for Harry Potter, an example of this is Snape. Snape is very much like a loner and has that flattened affect and appears very cold and detached, or also Gollum from Lord of the Rings. Then we have schizotypal. So these are our kind of odd belief, magical thinking, eccentric. They can have paranoid ideation, inappropriate or constrictive affect, behavioral can be odd, eccentric, few or no close friends, and excessive social anxiety. So example of these from Harry Potter would be Luna Lovegood, or when I had to remember these personality disorders I always thought Charlie and the Chocolate Factory was the one I would think of for this. Then we have cluster B disorders. So these are the ones you're going to see the most common. These, again, are patterns of perceptive affect and interpersonal disruption. Disturbances are usually not to the psychotic level, although they can have brief psychotic episodes when under stress. Cluster B may require hospitalization during periods of active symptoms when they're under significant stress. Cluster B are in degree of affective instability, a type of interpersonal disruption and behavioral manifestation of those traits. And what you'll find if you look back in their history is a fluctuating emotional state and dramatic qualities to how the person lives their life. All right, so the first one is antisocial personality disorder. Usually this is diagnosed, it's usually for anyone 18 or older. We don't typically diagnose children with this, but you will see signs of it when they're younger. More common in men, has a higher comorbidity with substance use disorder, high impulsivity, often diagnosed as conduct disorder in children, repeated acts that are grounds for arrest, deceitful, lying, using aliases for profits or pleasure, impulsivity and failure to future plan, reckless regard for the welfare of others or disregard, consistent irresponsibility, lack of remorse or indifference to the feelings of others. When it comes to treatment, they may need CBT, but again, all of these personality disorders are very difficult to treat because typically they're ecosystonic and the people agree with their personality, right? So for example, this would be the Joker or Voldemort, right? You can think like Voldemort. Voldemort agrees so much with his personality. Like he is so ecosystonic. He thinks what he is doing is right, and he doesn't see anything bad about what he's doing. And that's typically how it is. I like to think of personality disorders like wearing rose-colored glasses. The way you see the world is just different. It's different than how others see the world. And it can be very difficult to navigate. All right, so now we're going to talk about borderline personality disorder. So there are multiple different criterias within the DSM-5 to diagnose this disorder. So here is just a list of some. So frantic efforts to avoid real or imagined abandonment. There's a big abandonment component with borderline, where they feel like they're going to be abandoned again or scared of abandonment. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idolizing and devaluing, identified disturbances of feelings of emptiness. They have an unstable self-image or sense of self. They have impulsivity in at least two areas that are self-damaging. So this could be spending, sexual relationships, substance use, reckless driving, binge eating, recurrent suicidal behaviors, gestures, threats, or self-harm. Affective instability due to marked reactive of mood. So they could have intense episodes of dysphoria, irritability, or anxiety lasting a few hours and only rarely more than a few days. They have a chronic feeling of emptiness, inappropriate anger or difficulty controlling anger, and transient stress, paranoid ideation, and severe dissociative symptoms. Now, people don't need to have all of these symptoms. These are just some symptoms that you might see. All right. So in borderline personality disorder, the person is thought to have not fully developed object consonance. So object consonance is like, if I take this hair elastic, right? I can see it, it's here. But if I sit on it, I can no longer see it. Is it still there? Right? I know it's still there. Or if I hide it, right? Is it still there? I know it's still there. It still exists in the world. It's just somewhere else and I can go get it and I'll see it again. It's like when kids play peekaboo. When you learn peekaboo, right? You learn the person is still there behind their hands. That's learning object consonance, right? So with borderline personality disorder, they don't fully develop that. So if that person they're attached to is not there, like they go to work or they go with their family or they go somewhere else, right? That person feels that anxiety, that intense fear of abandonment. They feel like that person may not come back. That person may leave them. So that's kind of that. So intense emotion or fears and abandonment occurred when confronted with a loss in a close relationship. The intense emotion leads to the behaviors of desperately clinging and extremes of emotion displayed by the person when their significant other leaves. If the significant other is away, the person with borderline has a hard time picturing them returning and can become angry or ignored. The person has feelings of anger and rage. It's predominantly in women, often with positive history of significant childhood physical abuse, sexual abuse, neglect, or early parental separation or loss. Frantic efforts to avoid real or imagined abandonment, patterns of unstable, intense interpersonal relationships, identity disturbances, impulsivity, often with self-damaging behavior, recurrent suicidal behavior, chronic feelings of emptiness, inappropriate, intense, affective anger responses, and transient psychotic symptoms of paranoia or dissociation. And so our characters are Beth from Fatal Attraction or Myrtle. You remember Myrtle in Harry Potter? She's like crying in the bathroom. She's like, "You're going to leave me." Like that's the best I get. Okay. From Harry Potter, at least. I tried to do one from Harry Potter for all of these. So borderline personality disorder occurs in 1 to 2% of the population. It's a 2 to 1 female to male ratio. 8 to 10% can die by self-harming. A perseverative course, abrupt changes in mood, typically changing within the hour. They can have, thoughts about hurting themselves or actual attempts at hurting themselves. They can have transient psychotic symptoms. NSSI is I don't want to say the word, but non-death, I guess, right? Self-injury, chaotic interpersonal relationships, significant history of trauma, and highly comorbid with mood disorders, PTSD, substance use and eating disorders. Treatment first line is psychosocial or behavioral interventions, and we can adjunct with psychopharm if we think it's going to help. So really the number one gold star treatment for borderline personality disorder, and this you should know for the exam, is DBT. It's dialectical behavioral therapy. It was actually created by somebody Martha Lingahan, who has borderline personality disorder, and she's very smart and she developed this and it helps. Borderline personality disorder as a disorder of emotional regulation system that activates a behavioral pattern of instability as a coping mechanism. DBT proposes 4 guiding skills as its fundamental learning goal: awareness, interpersonal effectiveness, emotional regulation, and discomfort tolerance. Mindfulness skills as one of the main 4 training modalities in DBT help people to develop positive physical and emotional responses to stressful stimulations that improve their depressed mood. So again, some notes on borderline. So there's an impairment in personality functioning. So due to excessive self-criticism, emptiness, dissociation under stress, unstable self-image, compromised ability to recognize feelings and needs of others, perception of others selectively biased, intense, unstable, and conflicted relationships, extremes of idolation and devaluation, pathological personality traits, so emotional lability and anxiousness, feeling or falling apart of losing control, feel of abandonment, depressive feelings of being down, hopeless, and miserable, pessimism, thoughts of harming themselves, impulsivity, high risk-taking behaviors, hostility, and antagonizing. Again, someone will not have all of these things. You just have to have like a certain amount. Then also like people can have like borderline personality disorder traits, right? They might not meet the full criteria for diagnosis, but you get the gist. So then we have narcissistic personality disorder. So this is a grandiose sense of self, preoccupation with fantasies of power, success, brilliance, and beauty, belief of self-importance and being special and unique. Excessive admiration is required, unreasonable expectations or sense of entitlement, interpersonally exploitive, empathy lacking, envy of others and belief that others envy him or her, and arrogance and haughty behavior. So we can think of Gilderoy or Gaston from Beauty and the Beast. All right. Then we have histrionic personality disorder. So they are uncomfortable in situations in which he or she is not the center of attention. Interactions with others are characterized by inappropriate, seductive, or sexualized or provocative behaviors, rapidly shifting and shallow emotional responses, consistent use of physical appearance to draw attention to themselves, speech excessively impressionistic and lacking detail, suggestible and easily influenced, and relationships considered more intimate than they are. Someone with histrionic personality disorder, the big thing is they need to be the center of attention. So if for whatever reason they are not the center of attention by using things like being seductive and things like that, they will even go to the extreme of like causing a problem to be the center of attention. So it doesn't always have to be, they have to be the center of attention in a positive way. They will do something negative to be the center of attention because they cannot not be the center of attention. So this could be Bellatrix or Regina George. So cluster C disorders, these are patterns of pervasive anxiety and fear. And again, they can have brief psychotic episodes under a lot of stress. Cluster C are to a degree of the anxiety and fear in a behavioral manifestation of those traits, and significant history includes avoidant behaviors, procrastination, difficulty following through, fearful of rejection and criticism, and difficulty relaxing. So avoidant personality disorder, we must first consider cultural variability when we look at avoidant behavior disorder equal for both genders, avoidance of activities involving significant interpersonal contact, fear of criticism, disapproval and rejection, unwillingness to be involved with people unless sure of being liked, restraint in intimate relationship for fear of being shamed, preoccupation with being criticized or rejected in a social setting, view of self as socially inept, personally unappealing and inferior, an unusual reluctance to take personal risks or engage in new activities. I couldn't really think of a character that this fits fully, so the best I could find is Hagrid kind of fits this. Then dependent personality disorder. So this is most frequently diagnosed personality disorder. Rates are higher in women than men. Usually diagnosed in people with a history of chronic physical illnesses, difficulty making everyday decisions without excessive advice, needing others to assume responsibility in most areas of their life, difficulty expressing disagreement, difficulty initiating projects by him or herself, going to excessive lengths to obtain nurturing and support from others, urgently seeking of another relationship if a close relationship ends, and unrealistic preoccupation with fears of being left alone. So this one I thought of Peter Pettigrew from Harry Potter. Then we have obsessive compulsive personality disorder. So usually this is in men, which I thought was interesting when I was doing my research and reading. For some reason, I would think obsessive compulsive personality disorder would not be more in that gender, but it is. I guess maybe because it's so close to OCD, right? The name, this is one of those, it's too close. But symptoms similar to, but less severe than obsessive compulsive disorder. These people are preoccupied with details, rules, order, and organization, perfectionism that interferes with task completion, excessive devotion to work and productivity, overly conscientious, scrupulous, and inflexible on issues of morality, inability to discern worn out or worthless objects, reluctance to delegate tasks to others, an adoption of a miserly spending style towards self and others, rigidity and stubbornness. So Dolores Umbridge from Harry Potter, I would say, has this. So pharmacological management. So There's no specific class of medications that are used to treat personality disorders. However, we can use medications to help some of the symptoms that they might be having. So, for example, impulsivity or affective instability, we can use anticonvulsant mood stabilizers or SSRIs. If they're having anxiety, we can use benzos, non-benzo anxiolytics, and SSRI. Non-pharmacological treatment is more common for personality disorders. It focuses on issues of limit setting, projection of self-harm, improved coping, and enhancing interpersonal functioning. Can be used such as case management and then psychotherapy, again, focusing on interpersonal skills and coping, alterations of patterns of behaviors. Forms of therapy, we have DBT, psychodynamic therapy, interpersonal therapy, behavioral therapy, cognitive behavioral therapy, and milieu therapy. And we'll talk more about this more in our non-pharmacological discussion. So in children, before diagnosis is determined, significant life experiences must occur. So chronicity of maladaptive patterns can be observed. Features of personality disorders usually become apparent around adolescence to early adulthoods. It's unusual for somebody to be given a personality disorder diagnosis before 16 to 18. With the exception of antisocial personality disorder, which is not diagnosed until 18. And if they are displaying signs of that before 18, it's conduct disorder. Separation anxiety and chronic physical illness often precedes and predicts the onset of dependent personality disorder. These are chronic disorders and clients may be resistant to change. Relapse is common and frequent. How long to treat and success rates vary. Prognosis is poor without treatment, and prognosis is improved if treatment happens early in life, like teens to 20s. And again, I like charts, so I feel like this is a nice chart that kind of shows all the differences of the personality disorders, right? So, for example, people on the more dominant spectrum, they're more likely to be narcissistic. People on the more submissive spectrum might be more avoidant. People more detached are going to be schizoid, more attention-seeking, histrionic, more needy, they're dependent, more hostile and self-centered, antisocial. So this doesn't have all of them, but it has some. All right, and that is our discussion on personality disorders. I'll see you next time. Bye.